Hi, it's Jonathan and Amaali, and welcome to Cut to the Case.
Hi.
Amaali's here, which means we're talking ultrasound. And look, I've got a case. This is a really common thing, Amaali, but I just wanted to go through what you do with this, how you manage, how you work this situation out. And look, here's the case. Okay, you ready?
Mhm.
We've got a 60-year-old man. He's come in, he's in agony. He's in the waiting room. There's no cubicle. He's in agony. He's got right-sided loin to groin pain.
Mhm.
Can't get comfortable,
Mhm.
rolling around, bit of frequency. What am I talking about?
Well, it sounds like renal colic.
It's kind of renal
Whoa.
colic. Barn door. There's no issue about diagnosis here. So well, maybe there is.
But there is.
There is.
He's 60
Right.
and renal colic presenting as the AAA presenting as renal colic is one of the most common.
Yeah, so you know, the old issue of what's the differential diagnosis of renal colic. Clinically, I think it's renal colic.
Yeah.
I'm gonna examine him, take a history. Has he got previous stones? Has he got vascular risk factors? I'll get a urine dip. Guess what? Urine dip, he's got 2+ red cells in the urine. So I'm pretty happy it's renal colic.
I'd still ultrasound him in the DAT office.
So
I would not let him leave before I ultrasound him.
And the DAT
Or
office,
AAA.
and that's our little office we have sort of in the triage assessment area. So the way we have things set up, you can actually pull them in out of the waiting room and do an assessment. And I suppose the reason I want to talk about this is for a long time, I've just been ordering CTs on these people. I've been going, this looks like renal colic, it smells like renal colic, looks like renal colic, it's going to be renal colic. A CT will make the diagnosis. But is there a better way?
Well, I think ultrasound gives you the diagnosis at the bedside in most patients. And I would do that because then you can shut that off from your brain and just wait for the CT, put him in short stay. And if it is a AAA, then you move them to resus. So you get a good.
Oh, okay. So we got like a branch point in this 60-year-old guy. So we're going to do an ultrasound, look for a AAA, look for a stone, but you're still going to do a CT.
If it's a first presentation, I would do a CT. Especially in the older patient, because it could be other pathologies.
Just out of interest, not that I'm anywhere near 60, but
well, our protocol is more than 50. Is
more than 50? It's not. Okay, seriously, 50. All right. So
first presentation.
So that's reasonable.
Older patient.
First presentation, older patients, so over 50.
Yeah. Pain not settling is another thing because it usually first dose of NSAIDs analgesia, it settles down. If it doesn't, even if it's a stone, it could be a ruptured calyx or a really big stone. So urologist is more likely to be interested. Any signs of UTI, fever, infection, anything like that is an obstructed kidney. So then you need to have a CT.
Okay, so that'd be the reasons for a CT.
And abnormal renal function, but you get that later.
Yep. All right. And so duration of pain?
No.
Is it? No. Okay. Doesn't matter. No. Or it matters, but it's not.
Unless it's been like weeks. The guy's gone to his doctor for a couple of weeks and then you'd obviously scan.
So if I'm doing, say I'm doing ultrasound, okay, I've got the guy in, and I'm not great at doing, renal ultrasound. Can you just give me the basics? So how do I do it? What am I looking for? Where's the bang for buck?
So what I do is everyone knows how to do fast. So you go to your right up quadrant or left up quadrant view, and instead of focusing on Morrison's or the splenorenal recess, you just translate your transducer caudally, so towards the patient's feet.
So translate, move up.
Move down.
Move down. Okay.
Towards the patient's feet.
Yes, don't go too fast here. We're translating. Yep. Okay. Yep.
And then angle down into the spine so you get more of the kidney. So you want the kidney in the middle of your view, not the liver or the spleen.
And like you're showing us here. Okay. So this is the kind of how you get the good view.
Yeah. Exactly.
Okay. So now I've got the view of the kidney. What am I looking for?
You slice through the middle of the kidney so you can see the pelvis like this, and you want to see the pelvis full of fat. If it's full of fat, there's no hydronephrosis.
Okay.
But if you see pelvis looking like this, where you've got anechoic fluid within the pelvis, that's hydronephrosis. So grade 1 hydronephrosis is this, where you just see the pelvis and a bit of calyces being dilated.
Okay, grade 1, yep.
Grade 2 is where the calyces look quite dilated and they're starting to get a bit rounded. Grade 3, they're quite rounded. Grade 4 is where the cortex becomes thin as well.
Okay, so 4's got the thin cortex. How do I tell between 2 and 3? Is that?
So
Is there a
3 has rounded calyces. So the
Yes.
calyces, instead of having the like the club shape to them, they
Yep.
get round.
Okay, so they get round.
Yeah.
All right. And so what's then?
But the grading is not so important.
Yeah, right.
Like you
Yeah.
got
Yeah.
it should be a yes/no question. Hydronephrosis, no hydronephrosis,
Okay.
because that gives you your diagnosis.
So when so to keep it simple, when do I call it hydronephrosis?
When you can see a dilated pelvis.
So dilated pelvis. You got a dilated pelvis, I've got hydronephrosis.
Yes.
And how?
And the only thing with that is that you can have a pelvis that's kind of dilated congenitally.
Yep.
Or you can have pelvic cysts.
Okay.
But I mean, in ED, it's a yes/no.
So there may be some caveats. But if I'm
Caveats,
seeing a dilated pelvis,
Yeah.
I've got hydronephrosis.
Without that there, that's a hydronephrosis.
And then how good is that? I mean, how sure am I that this is now renal colic? I mean, how sensitive is it? I mean, does it confirm the diagnosis? Boom, yes.
Yeah.
Or do I need to do something else?
Well, it shows that there's an obstructed kidney.
Mhm.
It could be a lot of other things that cause an obstructed kidney.
Yep.
So you think the ureter is going to go all the way through. So anything retroperitoneal that obstructs the kidney, ureter is going to cause it, like pregnancy,
Yep.
like masses
But
and things like
in our
that.
clinical
But
context,
in a clinical context,
this guy, the
pretty much,
60-year-old,
that's it.
blind to groin pain,
Yeah.
hydronephrosis, dilated pelvis,
renal colic.
boom.
Yeah.
Okay, all right. So you've done the scanning,
Mhm.
you've seen the hydronephrosis.
And always look at the other side, because
Okay.
you want to see, is it bilateral?
Check the other side.
Is the other side looking
Is
kind of the
it
same?
bilateral? What's your next move? Do you move down to see these
I do.
ureteric
I
jets?
go. I
Or
try, because I like looking at it. I try and follow the ureter down.
Yep.
Because the ureter goes on the psoas muscle, so you can sometimes see it going down, and you can sometimes see a stone.
Oh, so you can see the stone.
Mid-ureteric stone,
Yeah,
right?
okay, yeah,
Sometimes you can see that.
Yeah.
And then,
Yep.
but mostly it gets obscured by bowel gas, because then I go to a transverse of the bladder.
Yep.
And I look into the pelvis, but I fan quite anteriorly to try and get the bladder trigone,
Okay.
where the ureters are coming in.
Like this, like
Yeah.
we're doing here. Yep.
And
Okay.
then you should see a dilated ureter on that side.
Right.
And sometimes you can see a hypoechoic stone.
Yep.
And then if you put collar on it, it'll twinkle at you. So that makes me happy.
All right. So the twinkle. And so when it twinkles, what does that mean then?
It's just a stone. The stone, because of the funny calcium deposition, it twinkles at you.
All right. So is that ureteric jets, or is that
No.
that's
So
something?
ureteric jets used to be in the old days where you'd sit and wait looking at the trigone for the ureteric jets to happen.
Yep.
And the theory is that there's an absent or a decreased jet on the side of the obstruction.
You're saying used to, so we're not doing that anymore.
I don't do it because you have to wait for so long.
Yeah,
It's so
exactly.
boring.
I'm glad you said that.
It's like, oh,
That sounds
this
really
is
boring
boring.
in something in our little recess room. So in our little chat room. So
yeah.
so just let me summarize what we're doing. So get him in. We're looking.
Check for AAA first.
Check for AAA first. And that's another chapter. We can do that another time. Look at it, right upper quadrant, translate down, angle down, look at the kidney. Have I got hydronephrosis? And we've seen the pictures for that. Look on the other side to compare. Is it some sort of congenital thing, or is it blockage lower down? Trace the ureter down to see the stone. You might see a stone.
But that's just for fun. You don't have to do that.
Just for fun. Okay. And then we get down to the bladder. We might do ureteric jets, but we may not. Sounds like they don't add a big
More
bang
look
to the
for a dilated ureter and a ureteric stone, because if it's at the VUJ, you're more likely to go, hey, it's going to pop out soon. Don't worry too much.
Yeah. Okay. So that's actually quite useful, isn't it?
Yeah.
So if I said high up
Yeah.
and 3 days of pain or something, I might be able to, that might inform my disposition plan. Can you, on ultrasound, measure the size of the stone?
You can, but the problem is it's just not accurate enough. So a small stone may look big, a big stone may look small.
So that probably means you can't.
Yeah.
That probably means it's not accurate.
The only helpful thing for a big stone is
Yes.
you've got a high grade of hydronephrosis. It's more likely to be a big stone.
Let me ask the question a different way. You scan this person, you see hydronephrosis. When is it a definite urology consult? When does it mean this is a big stone?
Yeah, so if it's grade 3 or more hydronephrosis, I'd definitely get a CT scan.
Yeah.
And I'd ask urology. So unless they've been drinking heaps of water, getting that grade hydronephrosis means the stone's been there for a long time.
Yep.
Or it's a big stone.
Okay. So grade
full obstruction.
So if I'm thinking right now, if we see some early hydronephrosis, I've probably got I've ruled out the AAA, early hydronephrosis,
Low grade. Yeah.
low grade,
Yeah.
probably right with renal colic.
Yeah.
But if I've got a grade 3 hydronephrosis,
Yeah.
this is probably something urology need to get in, or
Mm.
in our service, urology need to get involved with, because the stone's probably stuck.
Mhm.
All right, sounds good. Anything else we need to talk about with renal colic?
Only a little cool thing that can happen. So if
Cool
you've
thing.
got
Yep.
fluid around the kidney,
Yep.
that means perinephric free fluid could be a ruptured calyx, and then
Okay.
they'd have lots of pain, and
All
you'd
right.
scan those as well.
Okay, so that would need a CT scan.
Mm.
So I think it sounds like there's a place for ultrasound. It sounds like it's just giving me a little bit more clever information I can deal with, and I could probably make an early urological consult. They're going to want a CT anyway, but it'll put me one step ahead, and that's what ultrasound's all about, really, isn't it?
Exactly. And once you go, oh, I know what it is, I'm not worried about that patient anymore.
I'm not worried. Okay. Well, thanks, Amaali. That's fantastic. So that's renal colic and the use of ultrasound. See ya.